Next, we're going to perform the female pelvic exam. Again, observation is key. We're looking for the hair distribution. We're looking for Tanner staging in a adolescent patient, and we're also looking at the external anatomy. First, the labia majora, the labia minora, the clitoris at the top, which is an area to be avoided with a speculum. And if we part the labia, I'm going to show my hands in this position, but for the purposes of the video, I'm going to move down here to demonstrate the urethra, which is where you would catheterize a patient. Additionally, probably difficult to see, there are rugae lining the wall of the vagina, and this indicates that it's an estrogenized vagina. As women go through menopause, the walls become smoother and more atrophic. Next, we'll move on to the speculum. This is the most common type of speculum that you'll see in your clinic. It has a battery light source, which activates by pushing inward and deactivates by pulling backward. One of the things that you'll get used to and better at is not allowing the clicker to make noise. So as you spread the paddles, most women don't want to hear that. So as you tighten this, you're going to lift first and then open the bills and then lower this back into place. We usually don't use this adjustment, but this adjustment opens the proximal portion of the instrument. So if you need a better view up front, you can push here and you can see that that part also goes up, and I did a bad job avoiding the click on that one. So push in, push up to avoid that clicking noise. It takes a little practice, and the more you handle these, the better you'll be. The next part is lubrication. And typically, we try not to over lubricate because that leaves too much debris, for lack of a better word, and this can be very cold. So you want to use just enough, and in fact, I like to wipe it on, not wipe it off using the paper towel. And again, I do this with a rectal exam too, so it applies a coating. I'm not wiping it off, I'm applying it in a very thin layer. So next, I'll make sure to tell the patient what's about to happen. You'll feel my touch on the inside of your leg. And now on the outside, you'll feel my fingers. We'll part the labia. We'll start the insertion with the speculum at a 45-degree angle. Again, that's to avoid the sensitive areas at the 12 o'clock position. So at 45, we're going to insert, and you want to try and apply more pressure downward or posteriorly. And the nice thing about these specula is that they have see-through bills, if you will. And there is the cervix. I've isolated the cervix and trapped the cervix, and that allows me to have access for pap smears and other procedures. As you come out, watch carefully. You're going to lift on this so it doesn't click, and you're going to rotate outward and slowly allow the bills to close and come out. If you let go suddenly, the bills can pinch the inside of the vagina, causing pain. So please avoid that. So with the insertion of the speculum, make sure all the adjustments leave it minimally open. I'm going to part the labia, insert at a 45-degree angle. You're going to pull posteriorly, and as you go in, you can open until you find the cervix. When you remove, the steps are reversed. You release the spring tension lever, and you're going to rotate and slowly close the bills and exit at a 45-degree angle. On your OBGYN rotation, when you're watching procedural exams, you'll notice that they use a Pedersen speculum, which is basically a metal version of what I just demonstrated. There are a few differences. The first of which is this hook on the bottom so that you can apply posterior traction to increase the exposure. They also have thumb screws so that you can lock the bills of the speculum open, and likewise the anterior opening or proximal opening is also adjustable here and can be locked down. You'll notice there's no light source, so you need to be very carefully adjusting your external light source to provide illumination down the bills of the speculum. This is lubricated the same way, inserted the same way. The one difference is this is not transparent, and so as you come out, in order to get an exam of the entire mucosal surface, you want to rotate the bills so that you can visualize the other part that was previously covered with the bill of the speculum.